All right, Pedro and our audience of CCC Live, structural cases, welcome from Mount Sinai Cath Lab, and we all have our usual speakers here and operators, myself, Samin Sharma, Dr. Kini, Dr. Gilbert Tang, and Sahil Khera. So this, and of course we have our one interventional fellow, Taka, and rest of the staff, and Dr. Lerakas is on the echo.
Yes.
With that note, clearly we want to show all different varieties. We have done the tower, TMVR, and now going to show today the M-TEER with the mitral clip. These are our live cases supported by Pedro, of course, your moderator, and our anesthesia, Dr. Mark Stone. So somehow there is a no battery, or the clicker is not working. Yeah, it's working okay now. So this is the M-TEER using MitraClip G4 system for A3P3 prolapse. So a little different. This patient is an 80-year-old female who has decreased exercise tolerance. Risk factors we shown, but more importantly, patient is frail because of severe knee arthritis. And 64 echo showed 64% EF with moderate to severe MR, and we'll ask STEM to point that out with the A3P3 prolapse, and revealed also massive TR and biatrial dilatation, moderate pulmonary hypertension, coronaries are normal, patient atrial fibrillation. This was the old picture, and maybe now we can show the live picture by STEM.
Yes.
EF is 64%.
Thank you, Dr. Sharma. Good morning.
Yeah.
I don't know if you can see. Yeah, this is deep gastric image, short and long axis of the LV, which is normal, no pericardial effusion. This is a mid-esophageal view, normal LV function, normal RV function. As you can see, myxomatous mitral valve leaflets and tricuspid valve leaflets with a prolapse of the mitral valve leaflets. This is to show all the other valves in one view, some thickening of the aortic valve with decreased excursion, but no significant stenosis. Mild PI, at least moderate tricuspid regurgitation, minimal AI. So this is the mitral valve. This is a bicommissural view, and as you can see with the X-plane, we're in the medial part of the mitral apparatus, and you can see 90 degrees on the other side, the valve, the leaflets at that point, and this is the mitral regurgitation, moderate to severe mitral regurgitation with PISA about 0.9 centimeters, and this is the medial part, and that's what we do. We scan through the mitral apparatus with the X-plane. Now I'm in the middle of the mitral apparatus, as you can see here with prolapse of A2 and P2 scallops, and this is the color in that middle part of the valve, and this is the lateral part. As you can see, minimal again mitral regurgitation. So the most of the jet is at the medial part, and this is a 3D image, which we can see a Barlow's mitral valve with a significant prolapse of almost all the scallops, but mostly on A3, P3, and P2, as you can see here, with a white jet in that location. So this is important for where we put the clips, and this true view of the mitral valve with the color again in the medial part, A3, P3, and this is glass view, and the valve area is 7.2, so pretty big valve for the clipping procedure with a mean gradient of 1, and here you have blunting of the left pulmonary vein, which is good to follow after the clip is placed, or clips, and this is the bicaval view where you can see we have a lipomatous septum, which may make the Transseptal puncture a little bit challenging, but we have the best team here to handle this. Thank you very much.
Okay, now so maybe STEM for the audience, you can define, teach us what is moderate MR, what is moderate to severe MR, and what is severe MR in terms of the regurgitant volume and orifice and so.
Yes. So usually with, and because of the time, I did not do this here, but we measure EROA using the PISA and the continuous Doppler, and not usually, but EROA of 0.2 to 0.4 is moderate mitral regurgitation, more than 0.4 is a severe mitral regurgitation. Regarding volumes, about more than 50 ml is severe mitral regurgitation, 20 to 30 to 50 is moderate. So that's
Beautiful.
how we do that, yeah.
Okay, Fantastic. Go back to our presentation, please. So from echo point of view, all has been shown. We'll just kind of additional views. We just go through it. So go to the real actual case presentation. Actually, I wanted to talk to here Gilbert also. More and more we are seeing now that concomitant moderate to severe MR and TR together. So what has been our experience here? What percentage cases which having, and how are we dealing with that? Let's say both are 4+ or both are 3+. What do we take care first? And so.
Yeah, no, great question. I think I would say 30% of our patients have multivalvular disease, well, not just MRTR, but also ASMR and even ASTR. So, obviously, if they're surgical candidates, surgery is the first choice because you fix everything at the same time, and even Afib. But if they're not a surgical candidate, then we usually stage it. So staging, the first is mitral because, we go from left side to the right side. So we determine if the left side mitral valve is suitable for transcatheter intervention. And if so, which? Because now we have repair and option commercial, but also we have trials for replacement. And once we fix the mitral, we typically, at 30-day follow-up, reassess the tricuspid. If the tricuspid need to be re-intervened, then now we have two commercial options. We have both repair with TriClip and TMVR with Evoke. So determine on the anatomy and imaging complexity to decide which option we pursue for the tricuspid side.
Okay. And Sahil, from your point of view, so many of these cases, maybe 5 or 10% we close the ASD. And if you need to repuncture the ASD, how do we do in those cases?
Yeah, that's a very good question. So iatrogenic ASDs sort of tend to close spontaneously, almost 90% of cases by 30 days. Rarely you end up needing a re-intervention. So we prefer more the Gore devices, which have less nitinol mesh than the Amplatzer devices for recrossing. So if you do anticipate that you have bidirectional shunting, hypoxemia, and you have to close, use a Gore device if at all. So it just makes re-intervention easier.
Okay. All right. So let's. So AK, you want to comment on that? With the both significant, we do on the mitral first versus tricuspid. Even sometimes mitral is 3+ and tricuspid is 5+, right? It's still in those cases.
Yeah, we finish the mitral, just hoping that the secondary pulmonary hypertension will be taken care and maybe some changes in tricuspid regurgitation.
Okay. Good. So coronary angiography, and so summary of the case. Patient has a low STS mortality, but because of frailty and because of arthritis, it was decided that patient go for S2S repair using mitral clip with a G4 via right percutaneous femoral venous access. All right, so let's show what we are now with the transseptal puncture and the actual performance of the device.
Okay, so for the transseptal puncture, the various devices that are available, but let's go from where we first started and where we learned. Come here, Damien, show us. Yeah, so the Mullen sheath. We learned actually Mullen sheath when in our original days. Bring here. So if you can show. Okay, you know what? Let me take my gloves out and later on I will show you. Yeah, this is the original Mullen sheath. If you see the curve, I don't know if they can see it. And this is a very useful if your atria is really dilated. And since we used to do it mostly for balloon mitral valvuloplasties, this used to be the best sheath available at one time before any procedure started. And for that, we needed the needle. Give me the Brockenborough needle. This used to be the needle that used to be used. Brockenborough needle, which is, very, you can see it, how the Brockenborough needle have to be used. We actually have on our Transseptal app and video of how to use the Brockenborough needle and do transseptal puncture. There is an app, Transseptal, where we did that. And subsequently, some other sheets came out, which are called the SL, and mostly the electrophysiology use this sheet. It's from Abbott. Okay. Now they come with, most often we use SL1. There are 1, 2, 3, and this is the needle. This is the other one. So that is just a sheet. And then if you are using the needle, where the new needle that later on came out was from the Baylis, where we use this important needle, which is connected, right? We are connecting that using the
RF.
my RF. So why we need RF is for when you're doing mitral puncture, right? Very important, you're at the right spot at the right height. So many times when we used to do it in a very early stages during using Brockenboroughs, we used to see, though you calculated the height above 4 centimeters, it would change later on. So it has to be precise, number one, and you wanted to make sure the transeptal puncture is nicely done without any damage to the septum itself. So that subsequently, that is why the RF needle came out. So our transeptal will be very precise. In the recent years, we have another device that has come, which is called a safe cross. The safe cross is what we are going to use today. That is here, you can see it. It is more, so all these other transeptal punctures need what is called as, you need a wire. The wire goes all the way up to the SVC, and then you will remove the wire and slowly start coming down under the TE guidance, okay, and move actually inferior posterior, because most of the time you want inferior posterior to get the height to get into the mitral valve. So here what they found is that since a lot of people are trying to use it, and the most critical part I think in a clip or any device that we are going to the left side is transeptal puncture, because of the height and whether you are mid fossa or posterior fossa. So this came out, that is essentially a little balloon. It's more like a swan. So from the inferior vena cava, you inflate the balloon, you use it, you go higher up, and then you can go up just like a swan, very safe. And then when you are there, you can then rotate it anterior, posterior, and when you think you are at the right spot, then you will use your, again, RF energy just to make the puncture at the right side. So very, very important why we are going from the older, simple, I would say cheaper Baylis to something that is using RF energy, because you want the precise spot to of the transeptal, so your height does not change, you're not damaging the your interatrial septum, and you are able to do the procedure at the right spot.
No, but the question still remains, why are you using this fancy device compared to your usual ones?
Okay, that's I think what we were discussing earlier. So if you see this septum, right? Look at how thick it is. Okay, and then the spot where we have to go is maybe 5 to 6 millimeters at one spot. Now, I actually told these people. I actually told them we have to show a challenge, because we show every other case very challenging, but somehow the team here felt, let us not use Baylis at all. Let us just go for a safe cross.
We have standardized use of safe cross here. If you have multiple leads, more than 3 leads in a patient has severe RA or LA dilatation, patients who have very small landing zones on the fossa with thick lipomatous septum. So these 3 cases we tend to use safe cross mode.
Okay. Very good. Just like, we had the whole protocol, just like where we use sentinel in the tower cases.
Can you show the ceiling?
Can we zoom here, please, on the safe cross device?
So tell them all the
ceiling camera.
So the equipment itself, this is a 100 centimeter sheath with a 75 centimeter working length. The dilator is 102 centimeters. The outer diameter of the device is 2.8 millimeters, takes an 8.5 French space, and it is fully deflectable. So you get 8.5 French of a deflectable sheath. It can also work as an Agilis deflectable inside if you're doing PVL closures. So really multi-purpose sheath for not only crossing, but also for using inside the left appendage.
No, and then more important is that you are going to inflate the balloon. You see that? The dye, we have connected the dye. Once we are reached the level of the atria, we are going to inflate the little balloon, which you will see.
And balloon purpose is to stabilize your puncture.
No, it works as a swan, so we'll be able to
safer
deflection of the car, and you are able to see it. So that is why when you have multiple leads, this is a better device.
Correct.
Many times what happens is when you are using your Baylis needle and there are leads, even with the TE, we get a little bit confused and understand which way to move. We're going up.
Can we show fluoro and echo, please?
Yeah, fluoro now, fluoro and echo. And also to our audience, please, we promote and we advise to make more
fluoros,
questions
please.
and so ask. Yeah.
So we are
Fluoroscopy.
just,
So you
you
can
see
see the
that
balloon?
balloon?
Good.
We on the fluoroscopy, you can see the balloon that's inflated. So we take out the wire, right? Now show the ceiling. Yeah.
Yep.
Yes. So this is the deflection. And
Block the whole system.
Do you want the T probe away or you're
No,
okay?
no,
we
this
can,
is
we
good.
can.
We need TE to see. Right?
You need T, okay.
Very anterior there.
yes.
So take the flex off. So again, 4 working motions here: clock or counter for the whole system, or flex or anti-flex for the balloon-tipped catheter. Sam, can you find the balloon, please?
We can see the balloon or there.
The balloon.
Still buried anterior. Take some flex off.
The balloon. The ball on the balloon.
Clock.
Now we are okay, I think. Oh,
Now I flex. Sam, can you find us, please?
Yeah, there. There was.
now we are there.
Still
Keep
anterior.
coming down.
Just come down slightly.
Can you show us?
Sam,
Yes.
can you find the balloon?
Yeah, there.
Okay, there.
There.
Find it just here.
There.
Okay, Stam, what do you think?
Yeah, you're in the.
No. I think we are good. Okay, I'm moving
in
it
the
a
thick
little
part.
bit more.
I don't know if you want to go a little bit posterior.
Stam, I don't think we have enough room posterior. You can see we're in the thick portion.
Okay, let me see. Can you freeze there? Freeze, please. Freeze. You measure distance from this thing here.
It is very important for the right transeptal puncture.
So you
Otherwise, process becomes so difficult.
No. Yeah.
About
Can you go a
3.8.
little higher?
3.8.
Can you go short aortic valve, short access, please?
Yeah.
No, it's not like that.
Pull back slightly. Just slightly, not too much. Good. What do you think here, Stam?
Explain.
Is it a bit low? Explain, brother. Explain.
Yeah. Let's just do it here.
Yeah, it's a little superior there.
It is not.
So pull
Need to
back
go.
a little more.
Need to go to the thinner portion.
Back more.
Explain, Prof. Keep it on.
What?
Good. That's actually better. So you're in the thinner portion now.
Just the junction.
Find it there, Prof. You need to get a regular
So
view.
Stam, we are as posterior as we can be. You can see that, right?
Let me go, Prof.
I don't see
one
the
view, one view
tendon.
there. 2D. Yeah. Explain. On there.
Too posterior.
Yeah. So
Now you are very posterior.
Counter
Yeah.
clock.
Now very posterior, bro.
Yeah, we'll fix it.
Let's just take it.
Counterclock. Counterclock more. Come anterior.
Come a
Slightly
little bit
more
more,
anterior.
little bit
Slightly
more.
more anterior.
Little bit more.
Good. Stay there. Yeah, that's
There,
it.
there,
I
that's
like
good.
it. Beautiful.
There's good. Yes. Yes. Take
Ready?
that-
Everyone likes it?
Take the
Yeah.
image, please. Yeah.
Sinake. We're through.
Yes, you're through. Yes.
Very nice.
Okay, to the image, please.
Beautiful demonstration. Look at this. And wire, boom.
No, now the deflation takes a little while. So also
You
what
are-
we can do though,
You're in the pulmonary vein.
it's not a company recommendation.
Okay,
We
bro,
can
explain.
advance this once the balloon is deflated.
Explain here,
Can
bro. Explain
advance a
in the septum.
little bit.
There, in the septum.
Septal dilatation with the
Yes.
catheter. Don't use a new balloon. No, you need to that.
No, I think we're there. You want to change the
No,
wire?
you can floss it. Okay.
No, I'm going forward.
Yeah,
Okay,
very
now
nice.
we're good.
Very nice.
No, do you want to change the wire or we use
Fusion,
the
no,
same,
No,
Same
this
one.
is it.
same wire, right?
Was there the
Okay.
fusion?
This could one little bit more. Yeah.
So beautiful flossing, precise. And also with the balloon tipped catheter, you can anticoagulate beforehand. So the patient is fully anticoagulated with an ACT above 400.
So therefore, you don't have to wait for the transseptal puncture usual teaching.
I mean, actually, now you have to give about 2,000 even when you are doing Bailey's RF.
Okay.
Because it could be that you're there for 5 to 10 minutes. Okay, so about 2,000 is always given. 2,000 to 2,500.
And now we are given how much in this case?
7,000, 100 units per kilogram.
And ACT is good?
400.
Oh, wow. All right.
Let it bleed, yeah. Okay.
Guide.
So very important with the guide. I think we have gone through these steps also in the past that we need to activate it. So with the wet gauze.
Sometimes we overactivate.
Good.
Look at that transseptal stamp.
Yeah.
What do you think?
What do you mean what I think?
It's perfect,
They
right?
usually put a live.
So when you have smaller margins, it's
Elena,
easier
no?
to use this device.
Put it on that side, yeah. Do some good things.
Good. Okay.
Okay.
So at the groin, there's a figure of 8 suture. Go nice and slow. Advancing. Give me a dry gauze. Okay, good. We have it. This has to be done under fluoro.
Again, please.
On the clinic.
Control, Dr. Kinney.
So once you have to go through the septum, just gentle to and fro. You see that? I could feel the pop. Clock, counter clock.
Okay, follow that. Yeah.
Show the septum, please, Sam, so that we can see the tenting.
Okay, 2D, bro. 2D.
No, you had
Yeah,
the image there already.
Okay,
Okay.
there.
Explain, bro.
Not yet.
Wire, pull the wire
more,
back
yeah.
a little bit more.
Still tenting.
Still tenting, yeah.
Okay,
Yeah,
now went
popped
through.
in. So
Yes,
you feel a pop here.
yes,
Very nice. Yeah, Dr. Kinney,
yeah.
let's keep this. So standard to any mitral procedures, you have a stand and let's fix this and go from there.
So the clock is facing you. Yes,
Neutral now.
neutral.
Take that minutes, right?
So get your wait. Sheath in first and then the wire. Yeah. Pull back.
Let's get the clip next, guys.
Flush. Pressure line.
On the ball. The ball on
So we have to connect the syringe.
Beautiful.
Keep pulling back. Now you flush.
Big jumbo flush, please. Thank you.
This step is very important to
See?
avoid any large
Decrease the gain.
air embolus.
All right, let's see the
All
pressure.
is done.
Let's
Stop
check pressure,
flushing.
please.
Now let's check the pressure. Can you show the V waves there?
Hemodynamics on the screen, please. Thank you.
Just on the lower corner. Picture in picture, lower corner. Good.
Good.
Want to read out the numbers. So we have V wave of 25 and a mean of 14.
Okay. So you see how we are entering with the clip. Blue to blue, we have to key in properly.
Beautiful. Keyed appropriately.
Gilbert, what's the importance of key?
The keying allows you to the stability and matching of the knob turns and so forth, so you know whether you are,
Come down.
turning in the right direction. If you miss key, if you have a certain knob turn, then you
Follow the
realize that it's
Follow
actually
the clip.
going the wrong direction. So that's how you.
Follow the clip.
So
yeah.
now I keep going slowly under fluoro and then I have to make sure it's straddled.
Yeah, follow the clip, bro. Follow the clip. Follow the clip. Follow it. Okay, follow it. Great job.
Good, okay.
Okay, the back
Stamp follow us, please.
Yeah, I follow you, bro.
So what's the meaning of
Explain,
straddle?
explain.
You see that?
Keep it there, okay. Keep it there, please, yeah.
The two rings are on the either side of the tip of the
Let me find, how to find the
sheath.
bicomius review, yeah. Okay, 2D,
Very
2D.
important, so that you will be able to manipulate the clip well. So
find the
movements
full
are
chamber.
medial, posterior, very gentle. Sometimes you can hit the commodine ridge, left atrial appendage,
Okay.
commodine ridge. Keep watching.
Okay, Prof. Explain.
Nice. So I'm
So you
going
can
more
see she's
medial.
coming from lateral to medial.
So
Very
now
beautiful.
a little bit of a straddling. I'm going to adjust the straddle. You see that? I did that.
Very nice.
Yeah.
Give it there, Prof. Yeah. Great.
What do you think about the trajectory there?
Should I add a little plus? You think we are okay?
Find the clip. Find the
Little
clip.
plus, right?
Beautiful.
Yeah.
Come,
Okay.
follow the
That's
clip.
actually
Follow
very
the clip.
nice.
Very good. So I think the trajectory is very good, right? We can open the clip.
Press.
That's very nice. So what do you think about the trajectory there? Do you guys
So
think
one
we need
step they
plus?
did was you move the clip handle here to make sure it is
Okay. You want to check the clippers?
Yes.
well,
So tactile,
Anterior,
anterior, non-tactile,
posterior, yeah.
posterior. Good. 3D, please.
3D, please. 3D. Okay.
so
Okay.
you have to mention that, right?
be
Your
bigger, Prof,
grippers,
if you don't mind.
so independent
Okay. Decrease the
grasping
gain. Okay.
is possible now
Okay. 3D
in
zoom.
this new generation.
Okay, come
Gilbert,
up.
do you want to talk about the next generation that's coming out?
No,
What
let
is
us
going to be
talk
different?
about this and then we can talk the next.
Okay. Oh,
Tell us.
unbelievable.
Look at that.
Unbelievable, bro.
I think we go a little bit more center, no?
Maybe counter, little bit counter clock, little bit. Yeah, that's good. I think that's good.
Should we go a little bit center?
That's good.
actually
That's
very
great. Yeah, that's great. Okay. We put some color, Prof. Yeah, on the jet.
Beautiful.
On the
On
jet.
the jet.
On the jet. Take that, Prof. Take that. Take the picture. Yeah.
What did you do?
Okay. 2D. Okay. We try to keep the apex at 6 o'clock.
Beautiful.
Dr. Tank is
Okay,
always
close. Let's
very.
go in.
Fluorocine. Let's remove all
Okay,
the
Prof. Let's go.
parallax.
Okay.
Follow the clip down.
So the steps were the same. Once your trajectory is okay, you open the clip, you check your grippers, which we did, and then you go with the 3D and make sure your positioning of the clip is at the right spot where the jet is, and which we did. Now everything looks good. I'm going to enter into the LV.
Okay, stamp.
Yes. Yes, sir.
Go to grasping view. Make
You have
sure
to
there's
tell
no
what's
spinning.
a grasping view, no spinning. I'm advancing slowly. There's a lot of bubbles.
Okay.
Move the parallax.
You want to see 3D? I think the clip turned a little bit.
Yeah, we'll fix it the other way. You want to make sure there's no parallax. It's very good here.
Okay, Prof, you want to put 3D? No, 3D, 3D. Up.
Okay.
Put
You
it-
can
yeah,
open here.
There, 3D.
Stam, you like it?
Yeah, let me see 3D, Prof. Okay, up,
Open.
please. More up. And decrease the gain now. Decrease the gain so we can see the clip. Decrease the gain. Decrease the gain. More decrease more. Decrease the gain more.
So Stam, is this 3D a norm routine that we do?
Sorry?
Or this is just confirming?
No, it's to confirm that you did not spin when you was going down.
On fluoro, it doesn't look like it's
Yeah,
spun.
I just want to
Okay,
confirm.
let's go back to the grasping view.
Yeah, 2D plus. Okay.
Okay,
Explain.
leave it there.
Explain. Yeah.
I'm pulling back.
Yes.
So as you do is you're pulling back, and then
Yeah, explain.
what you can do is anterior, posterior looks okay, right?
Beautiful.
No,
You have
so
both.
the
You have both.
posterior,
You
you
have
think it's a little bit?
We can always optimize.
Okay, now we
you have
optimize.
both.
Yeah.
Stay on.
Take the posterior. Take the posterior, please.
Grasping both.
Take the posterior.
We're grasping both.
Yes.
Beautiful.
Yeah. Beautiful.
Gris-
Beautiful.
Give some
Grippers are on.
Amazing.
Give some back.
Yes, and we are closing the clip. Yes.
Take it there. Keep it there. Keep it there. Yeah. Oh.
Go a little posterior. Do we have enough posterior there?
Yeah, you do. Can you freeze it, bro? Freeze it. Okay, move the scene like, yeah, go. Yeah, I think you do. I mean,
do? Okay.
Yeah.
Torque posterior a little bit.
Okay, live.
We never discussed
Yeah.
the leaflet length.
Yeah. We want to have, depending on the size, on what clip we use, 7 to 9 millimeters. 7 for the NT at least, and 9 for the XT.
Okay, so
I agree. Yeah.
can you put some color on?
Yeah.
So then look at that. Beautiful. You still want more posterior?
I think so. It's Barlow's disease. You want as much as we can.
Okay.
Okay, so how much
Okay, take the color off, bro.
leaflet insertion? Are you happy with that? You're saying you have to go grasp more posterior. Okay. Open it. So
Focus on the posterior, eh?
The posterior was non-tactile.
yeah.
Laura? You're going to open the clip.
Focus on the posterior.
Stamp. Keep on the grasping view, please.
Keep on the grip, yeah.
Leave it there. There. Open. So we're going to open it.
Yeah, you
Raise the grippers. Okay. And then
Stay there.
stay at that position and go more posterior.
Raising the posterior gripper only.
Yes.
Okay. Go more posterior.
So you see that? So we are pulling the clip up at the same time going posterior.
Okay, dropping now.
Okay.
Yes, yeah,
Good.
I see it.
Can you show me? Yeah. Okay,
I see it.
good.
I saw it.
Now close.
I saw it. Yeah, it's a long leaflet, you may think that you don't have enough.
So just to
But it's,
kind of.
That's why I'm
I
saying,
agree.
can you give us the leaflet insertion
you
length?
Can you freeze that, Prof? Freeze.
Better.
Okay, let's move the leaflet. Move the cine. Yeah. Yeah. Measure how much is the residual.
So V waves went down by 10 points.
Yeah. Measure it from the clip.
Around
from
5
the,
to 6,
From
yeah.
the annulus. No. Yeah, a little bit. Yeah.
Okay.
Yeah. Measure like.
You can, now we have to
how
say
much is
how
it?
you're
6,
measuring that,
8.
right?
No, it's more less than that. Yes. Okay. Finish, bro. 2D.
Yeah, let's look at color again.
Yeah. Color, please. Explain the color.
Yeah, I think it's
Yeah,
beautiful.
nothing.
So what we do is we do a medial to lateral sweep.
Yeah.
So we start medial to the clip.
Yeah.
To make sure we don't have anything more medial. Looks like we got less of that now compared
Yeah.
to before.
Almost nothing.
And
Yeah.
if you go for extend the cursor,
Yeah.
we now sweep lateral.
Go, bro. Yeah.
You saw there was a very broad jet initially. Now you can see that the
Yeah.
cursor looks good.
Lateral to the clip.
And then you can
Go,
see
go.
that here. Very good.
It's a beautiful result.
Beautiful result, I think. But we typically would add a second clip to stabilize, because primary MR, what we learned is that if you just leave one clip there, a month later you might get more MR because there's some more redistribution of the leaf, particularly in this kind of bileaflet pathology. And this is such a big valve, we don't think gradient is going to be an issue.
Yeah.
With primary MR, the data suggests you want to be mean grain less than 5. Or in terms of to avoid functional stenosis. With secondary MR, you can have a bit of better tolerance, but also at the same time, you don't want to, be too high, then you get functional stenosis. So, Stan, what do you think?
Yeah, it's a fantastic result. I think we should put one more.
Okay, I understand.
that's
But
good.
give us a gradient.
Can we also see gradients?
Yeah. Measure
Before,
gradient.
you are happy with the leaflet insertion?
Yes. The leaflet was very long. It was 1.7, 1.8.
Okay.
And it's more than about 10 millimeters in.
Okay. So we
And,
got that
show us
it
a
was
3D.
1.7, 10 millimeters in. So that is one thing. Leaflet insertion is very good. And the second thing you check is there's no, you have to get a
Show me a
gradient.
3D, please.
Yeah, 3D. Come up, 3D, please.
So we're checking the gradient.
2. The gradient is 2.
Okay, gradient is 2.
Can decrease the gain.
Beautiful. Beautiful.
Exactly where we
yeah,
want it.
Exactly where we want it. Good.
Good.
So a little bit more posterior.
Some color, bro?
No relaxation.
Yeah, nothing.
No, we have to show the steps
Right.
of releasing.
Okay.
Yeah,
They're
put some
showing.
gain,
They're
some
showing.
gain, because we
You
decrease the
want to
gain,
explain to
some
them?
gain. Yeah.
So you want to check the
Take the color
block
off.
first. You want to.
Can you focus on the ceiling camera how to release now?
Yeah, he is showing. Okay.
Ceiling camera.
It's okay. It's okay. Just
good.
leave it like that.
So you go to an open position to see if the lip clip arms open or not. They look pretty stable on an aleocranial view. Go back to a closed position.
Tight.
Looks very good so far. Now we want to go up on your drips. It's good.
So we like to keep it tight. You know, sometimes they're squeaking. It's okay. You can squeak. Because you know you don't want. Last thing you want is the clip.
So you see the chili peppers here? This is what's holding the locking pin together, right? So you want to make sure they're evenly separated out. There should be no knots here. Remove the chili peppers one by one. And you can see there's no knot here. Both the peppers, both the threads are pretty evenly spaced out. Slowly start pulling on the thread.
So this step you have to do it under echo and floral, okay? So you can see that what we're doing here. You just want to make sure the clip has not changed in terms of the arm angle.
Pretty solid there. Go to the open position again.
Slow.
Check it again. See if it opens up.
You have to do this slowly because there's been instances that you know it might open up. I see, and then you tighten it again. Tight. So we do 2 times tight now.
Good.
And then now we go back to small neutral. No, go back to neutral now.
It is neutral, yeah.
You have to 2 times tight.
Yeah. Okay. Twice tight.
Yeah. So twice tight, and then go back to neutral. So now we take the parallax. Why do we do this step? It's because so that we can see when the clip is released whether you have a change in orientation. That means you probably twisted the valve or there's some distortion. So
pins coming off now. And we expose the obturator groove. Groove's exposed. There's a big groove here. Make sure it's completely exposed. 8 to 9 turns.
Okay.
Deploying stem.
Yeah.
One for good luck. Grippers up.
Okay, so
Now just give it some time.
So let the heart do the work. You don't need to pull it so quickly, especially if you have a lot of AM or undo the AM. So you have to kind of go slowly to be able to see.
Look at that, beautiful.
And you can see there's absolutely no rotation of the clip on fluoroscopy.
Okay, so tell them.
Yeah. So now what we'd like to do is to bring the pin.
There was a lot of M. We undid the M. It was posterior, so we make it a little bit anterior.
Yeah. So if you have any plus, you go back to neutral. We didn't have any plus this time. And then we go in. Once you're inside, you're protected, and then you can. Now make sure you don't lose access to the guy, right? So give me a syringe.
Hold this.
So as you're coming out, again connect to the syringe.
Yeah.
So
now we have to aspirate to make sure.
The whole system is out.
You make sure, don't forget the linear loader flush, please.
The second clip.
And then, how does the MR look? Can I get the big jumbo flush, please?
Put the color, please. Explain. Yeah. Some color, please.
Flush. Okay, here we go.
So AK is going in with the second clip. You can see that here. Again, keying blue to blue is important. Keyed appropriately.
Not sure.
Okay, keep coming lateral.
Slow down the flushes, please.
So how important is fluoroscopy for second and third clips, Gilbert?
I mean, it's critical in my mind because you can see how close you are, more so than echo, number one. Can we look at the guy coming out, the clip coming out, please?
Yes, it's good.
And so what we like to do is to make sure that you are as close as possible.
Follow.
Now, as this is assuming that your first clip is properly oriented. Your first clip is not proper, and you cannot use the clip as a reference. So
same. I'm going to go medial.
Yeah. So we're now going to go lateral to this clip. It's going to be above. Okay. So the kidney is now turning.
So just for the audience, is that lateral is above and medial is below. So this is, we're going to add this clip lateral.
Good. Okay. Right there. Perfect.
Yeah. And a little posterior there.
On the clip,
yes.
So 2 posterior. So would you add a little plus here, or what do you think?
Well,
I am adding a little plus.
we're almost above the valve, so just be
problem with
careful.
plus is drops it down.
I think you're good.
So what we can do is you can use the A knob, right?
knob, yeah.
So what A knob does, you can gain height. See how it
Beautiful.
reflects the gain? And then what Dr. Kinney will do is to add some amp. So look at that. So see how what we've done is that we gain height. And now, so remember plus sheds height, right? It drops height. So you can even bring it back further.
Explain, Prof. Explain, yeah.
Yeah. So
Actually good.
Yeah. Okay, open now.
yeah.
We are opening and checking the grippers again.
Open on the clip, Prof. On the clip. Yeah.
Okay, tactile first,
Tactile is posterior.
TP,
Yeah.
and non-tactile
Yeah,
is
anterior,
anterior.
yeah, okay.
Beautiful.
Can we check the 3D again, Sam?
Yeah,
Just
yeah.
to
Can you
make
put
sure.
explain 3D, please? Yeah. Okay, 3D zoom. Yeah. Okay. Turn
Just to
around.
make sure that floor, please.
Okay. Bring it up.
Lord, Dr. Kinney.
Decrease the. Yeah.
So now I'm aligning the first clip with the second clip. So that's why I'm doing floral. So you can see here. Ideally, they want to be parallel to each other. We call it kissing clip because of the orientation. So we're just trying to optimize that here.
Should we go a little counter here?
Yeah.
Stan?
Counter a little bit,
counter.
please. Yeah. Yeah.
You're not 10 and 2 though. Just be
Yeah.
careful.
That's okay. That's I think good enough.
You're not 10 and 2.
Okay.
Can you show us 10 and 2 in terms of the
Yeah. Yeah. 10 and 2, Prof. 10 and 2. Change the Z axis. Yeah.
So
Counter
for,
clock, a bit counter
imaging,
clock.
Gilbert,
Counter
can you
clock
talk about what you're
there.
saying when you say
Yeah,
10
what I
and
say
2?
by 10 and 2 is that the commissural have to be 10 o'clock on the lateral side, which is on the left side of the screen, and then 2 o'clock on the right side of the screen. Otherwise, if you want to do a central clip, you should be 12 and 6, but your imager is not showing you that, so you think you're wrong, but you're actually not wrong. So in this case, yes, I agree with counterclocking a little bit, but now you can see you're still not completely 10 and 2. You're like 11 and 10,
Okay,
10 15.
For,
So if you rotate the z-axis, show a little bit more. See, now you see. So now you see it's actually, and on fluoroscopy, you confirm that your first clip is at the orientation that's proper. If you look at fluoroscopy now, you see that it's also similar. So you want to take the parallels of the second clip. So because you don't want to twist the valve with the second clip, you also don't want to interact with the second clip against the first one as well. So we can just show you the fluoroscopy. So you can see that here.
So this
Okay.
actually looks very good
Yeah,
here.
so you don't want to be too close to the, too far from the original clip, because if you do, then you can have a jet in between the clips. So can you go back to 2D now, please?
Yeah, happy. Yeah.
Okay,
Beautiful.
close and we go in.
Okay, Prof.
Very
Explain.
nice.
Explain,
Okay,
please.
grasping view, please, Tam.
Yeah. Okay, follow the clip, please. Yeah.
Okay, wait in.
Yeah.
I
A
wouldn't go
little bit
deeper.
more,
That's
please. A little
good.
bit more.
This is
Come,
good.
come a little bit more. Yeah.
More.
Actually, it's not bad.
It's good. It's
Okay,
good. It's
open.
good.
There. Yeah.
Remember, when you open the clip, it goes a little more. See how it goes deeper. So you have to be very careful. Open more. So we're ready to grasp now.
On the clip, Prof.
Tam, don't change
on the
the
clip,
view
Prof.
now,
On the clip,
please.
Prof. On the clip.
So we're coming up. Very nice. You see that how close we are getting it. Posterior is on, so I would probably get posterior first.
So TP,
Yeah.
taking TP, so posterior first. You can see the posterior dropping there.
Yeah.
Very nice bounce.
And then what we would do typically, watch the orientation.
Orientation.
Okay, Prof.
And
follow.
then, so what you do now is to close the clip a little bit.
And
Yep,
clock
close the
anterior.
clip to parallel, and then you clock a little bit anterior just to make sure it's in, and then you pull up a little bit more. Actually, we maximize pulling up already.
We did.
So, and then now you can drop the second one.
Dropping the second. So I'm not convinced we have second there, but
No.
we can touch base with Stam again.
First, yeah.
Yeah, because of the,
Because
There's
of
some
what?
rotation of the clip as
yeah.
well. So I'm going to lift up the second here.
Yeah, do we have the second, do we have the anterior stamp?
No,
Yeah, let's
you
look
have
at
it, but
this again.
not much. Now you do
Okay,
it.
now stay
you
there,
do it. Now
Stan,
you do it.
please.
Now you do
Stay
it. Keep it
there.
there. Keep it there. Keep it there. Keep it there. Keep it there.
Keep it there, please.
Keep it there, please. Yeah.
And dropping here.
Yeah.
I want to see it live.
Yeah. Yeah, you see it. Very nice.
Beautiful.
Okay.
A little bit
Yeah,
rotated.
both.
Hold on one second.
The other way. Good, stay there. Give back.
Ready?
Follow the anterior, prof. Anterior. Come to anterior. Yeah.
Beautiful.
Oh.
Very nice.
V waves zero now.
V waves have actually gone down significantly.
completely.
So let's see how it looks on color and look at, make sure we have good anterior leaflet insertion here. Because you can see, remember what we talked about the Transseptal? It was very challenging because it was very small spot. And what we've seen is something called septal fatigue. When you have septal fatigue, what you see is that, you know, you start losing height. And that's why we were having that issue here, not because our puncture was not good, but because, you know, when you steer, you actually have a little additional weight. So how does it look, Stan?
Yeah, that's
the lateral that we had before.
Yeah, lateral. Yeah, come towards me.
So let's do a sweep again. So we do the same thing. We do a sweep.
Medial to lateral.
Close to the second clip that we haven't deployed. Keep coming. This is between the two clips. Nothing. Keep coming. Keep coming, prof. Keep coming.
So that's the first one.
Yeah, a little bit through the clip. That's about it. That's about it.
Do we have anything in between? Because that's the question, right? Because right now we are a little bit further away from
come towards the middle.
From the first one.
Yeah. That's between the two clips.
Do we have a jet or no?
You have what?
Do we have a jet between the two clips or not?
No. Okay.
Okay. So let's show the audience a gradient and a 3D then.
Yeah, 3D. Yeah, let's go 3D.
And there's smoke in the left atrium. That's always a kind of positive sign saying that, you know, we've reduced the MR.
Okay.
Also, your V waves have significantly dropped down.
V waves almost obliterated.
Yeah.
Okay, bring it up to us. Yeah. Okay, take that. Okay,
Do we have any questions?
Put some color.
No questions so far.
Look at that.
Minimal, man. Minimal.
Okay.
Yeah.
Okay, gradient, please.
Yeah, gradient. Let's go, prof. Okay, gradient. Yeah. Continuous Doppler. Put it there. Yeah.
So we know from the baseline that this is a broad jet.
Okay.
So I think most people say, well, the first clip looks pretty good. We're going to leave.
Right.
But this is bileaflet prolapse. They have to understand the underlying pathology. And so we have seen cases now, right? We did the initial clip because the patient was sick. We didn't want to spend too much time. And so, you know, then they came back. So then we have to do a redo. So
I think there are three benefits of doing two clip strategies here. Number one is you minimize movement on your Barlow's valve. Number two is prevents SLDA. Number three is there's indirect annuloplasty effect of pulling the leaflets together. So there are multiple benefits of doing this and without much change in the gradient. So I think the key of Barlow's prolapse is to stabilize the prolapse.
So you can see on fluoro, the clip is not opening when I did the first final arm angle. So again, you go back to tight. And then now you have the drips up so that you can lubricate the lock. That's very important. So can we get a little bit more drips, please? So, and then what's he'll show you earlier, you unwind these two strings together to prop the rubber ring open.
Let me see the...
Need more
juice, please. Give some more juice here. Running out of juice here, guys.
Okay. Pass wave.
Damien.
Yeah, normalized.
So it's very important that you have some flush juice coming out.
Nothing.
Because if you don't, then the lock line will be dry, then there'll be a problem removing the lock lines, okay? So it's very important at this point.
Okay, prof, put the X-plane.
Can you send some more? It's fully open.
Gradient is 2, pulmonary veins normalized.
Okay. Show the pulmonary veins.
Yeah. Okay.
So don't rush this step, right? Because you don't want the lock line to be compromised. So
much better. All right.
This the
okay, much better now.
Show before and now.
Okay, so now we remove the
Oh, that was after one clip.
So we don't floss anymore. So we just kind of remove the lock line.
Okay.
Initially, there'll be a little bit of resistance. You put your finger onto the lock lever.
Very important. Please keep your finger on. You don't want the lock lever to come up.
Why is there so much resistance? Oh, there you go. Yeah. Okay, so now once you have certain thing, you see that it gives a little bit more. So it's very important for the tricuspid side not to go too fast. You don't want to floss the leaflet and damage it because it's like these lines, they're like flossing your teeth, right? Your gums. So when the tricuspid leaflets are much thinner, so we take our time to remove it. And again, you do it under echo and fluoro to make sure. Okay, so at one point you see the pink. The pink is bending you out of the system. So this point you can go much faster because there's really no resistance against the tissue. So again, we talked about this. So we're going to open slowly, especially with the XTs and XTW, because the lock level is more sensitive. So now it's neutral, and then I go tight again. Okay, and then now I go back to neutral. And you see that the clip has not opened. So at this point, if it opens, you need to make sure you close it tight to make sure you tighten again, because that's when it can happen, and you need to troubleshoot at that point. Okay, so again, we go back to the parallax free wheel. So you do the pin out, and you Dr. Kara has shown you. You expose the groove. We like to teach our fellows here that you want to see and feel it, because sometimes on the other side. And so Dr. Kara now will do their turn. We like to do it 9 turn. Minimum is 8, and then don't forget to disengage the grippers. Okay.
And the steps, how to come out?
So coming out here.
Yeah.
So if you go very posterior, go back to this kind of natural curve, because that means you have tension, I think. And also what I see is I just use my 3 fingers and gradually disengage. There's
Just
no
wait.
rush.
Sometimes
Okay?
no rush, yeah.
See? Okay. Now remember,
the key step here,
look
very
there.
important, you have to know how to get, so
Remove
this
the
is a sharp needle.
Yeah,
The risk of this sharp needle touching the atrial wall.
that's right. So you can see on fluoro, you can see, I would disengage and pull it into the guide first before you undo all the knob. That's kind of our preference, because then once it's completely protected.
Yeah.
Okay, so you can see.
But some movements have to happen,
Yeah,
so that
okay.
needle can touch the
So how does it look
groove.
now, Stan, with the final
let me see,
MR?
let me see, bro. Let me see.
Yeah, that's why you know the anatomy
and then
here.
when
That's
it
very
comes
important.
out, you have to
Explain
wait,
the center.
tell
Put
them
some
when.
color, please.
Go ahead.
So watch this here.
Okay, we're in the
As
center.
the clip is coming out, you want to make sure the
Come-
clip is inside the hubbing port.
come
It
lateral.
cannot be outside. So you wait till the silver marker.
Yeah,
Once you're at
this
the silver marker, put
lateral
your
jet
thumb
there. Okay, go the
on
other
the
way.
guide and you can take it out.
So when the silver marker is seen, that
Flush,
means
please.
that a sharp needle
going,
is
keep going.
inside.
Inside,
Otherwise, the sharp needle is exposed.
Yeah, nothing. Mild lateral. That was before.
But there's nothing medial anymore, right? Medial central.
medial whiff. That whiff there. See. That
So
whiff.
whiff is
But that's very medial. That's,
Yeah,
that's
very
we
medial.
did not
Yeah,
want to go there in the first place.
Whiff
So-
is
Very medial. That's what I'm
10
saying. Very medial.
RBCs.
whiff is, yeah.
Minimal.
Dr. Kinney, how do you define whiff?
Okay, professor, let's go.
10
3D,
RBCs.
3D.
So you see the second clip did have a little bit of rotation. I think that's because we're grasping was a challenging thing, but good thing is that it did not affect any MR. But one thing we typically do, we want to line up the 2 clips we call kissing clips.
Okay,
So good. Yeah.
Beautiful result, yeah.
Okay, now let's take this out.
Okay, so now let's show people how to take this out. Okay, Stan, can we show the septum, please? So,
Yeah, please, yeah,
so
yeah.
we
Okay,
always bring it out under fluoro and echo for 2 reasons. One is that you have leads, you don't want to knock off a coronary sinus lead or atrial lead.
We're
2, you want to be able to see you're not dragging or tearing anything
Okay,
on your way out. So see,
to measure
No,
the-
very
if it's
gentle
busy on the
motion.
phone, tell
We
them
go
we are
negative
closed.
first to bring it back,
Close
and
it.
then you assess the
Coming
ASD.
out.
It is zoom, yeah.
Good job.
Okay.
What you did? What you did?
Yeah, come.
All
What
right.
is
Well, any questions, Dr. Moreno, for us in terms of the audience and panel?
it? Done.
No questions. We are stimulating the audience now to send us your questions.
Okay, great. Well, thank you very much for watching. And this broadcast will be available later on today on our ccclivecases.org
No, but wait,
website.
Dr. Sharma may have his slides, right?
And we'll see
don't
if Dr. Sharma want to close this
Can
session.
you remove the
T-probe.
T probe?
Oh, remove it?
If you
Yes.
This is what I need.
Let's give 40 of protamine, please.
Is busy?
Okay, well, is panel up on the clock? If Dr. Sharma is
Done.
Okay, very good, 2 clips. So let's go through some presentations. I've been listening to this because there was a little urgency other side which you took care. So quickly go through various issues with the M-TEER. And the mitral regurgitation actually is much higher than aortic. and we know that a lot of mitral valve regions, pathoanatomic, that's why the results are a little different in some studies versus other. And we know that as a group, we just talk about the second, degenerative versus functional MR, and CLIP actually has come into the guidelines, particularly patients with the functional mitral rigors and high risk surgery. And of course, not every case is suitable. And when it is possible, we try to do mitral M-TEER. On that, one is the mitral clip and second is the Pascal. What is our experience with the Pascal? Why are we not doing much Pascal?
Well, I think that the two different devices. One is for the both MitraClips for both primary and secondary MR, and Pascal is only for primary MR. So, and Pascal is not key, so you have more flexibility in the system, and as a spacer, so it's a little bit different design. But our MitraClip experience has been, for the last 10 plus years, with the different iterations, and so it's really good to see that, how that might. Yeah, have advanced. So.
Okay.
So summarize again the answer for the Pascal we didn't hear.
Yeah. So, well, I am hearing a robo voice here on my headphone. So,
What happened is he didn't have his microphone
that's
on.
right, but we have some malfunction here. But what we're saying is that Pascal is indicated for only primary MR in the United States, whereas MitraClip is for both. And we've had over 10 years of MitraClip experience at Mount Sinai. So I think we're very comfortable with this procedure. You can see even for complex anatomy and do it in a very short and efficient time. But no, people, I think just like TAVR, right? You do what is you're most comfortable as an operator. So, that's what we are and where we are.
Yeah. So key is also that, what you're good at become. That's the key. And that's what we have been. And at present, as you know, majority of the patients are functional MR. The real growth has happened into the field of the TEER is on the functional MR. So almost 75 to 80% are the high risk degenerative. Now, what is happening is, besides guideline directed medical therapy is the base. Everybody knows that. Which I'm actually have a little question about, what does the GDMT and how long you should wait, and do you need to have all 4 medicines versus 2 medicines, and so on and so forth. And then question is the ideal cases for the mitral regurgitation, whether it's particularly those who are primary MR, degenerative MR, and they're good for clip anatomy. And that is what ongoing any device which is evaluating the mitral space had to go with a randomized trial against TEER. So transfemoral TEER, TMVR versus TEER are the part of the randomized trial, particularly where you can do the TEER, whether it's a complex TEER or a straightforward TEER. And then various risk group comes into where these being evaluated, and we know exactly that right now where is the M-TEER is available or approved is for high risk DMR, degenerative mitral regurgitation, or primary MR, and functional mitral regurgitation where surgery do not play much. Now, many of the cases are not suitable for TEER. So those cases will continue to be just having a single arm trial. The transapical, I think, is the history region, because every company is investing to make a transfemoral TMVR with a septal puncture. And even Tendyne may get little approval, which is approved in Europe already, but problem is it's a transapical. So key is transfemoral is the way of future. So I just wanted to here, low risk surgery, primary MR, low risk primary MR, go for surgery, no question. Then question comes only into the moderate to high risk in the primary MR space, and I'll show you where the field is going at present. Now, basically why is issue? Because it is all dependent on how good your TEER results are. So look at the primary MR and secondary MR. Whatever your residual MR left is proportionate to the mortality, which could be 2 times or could be even 3 times. You can see secondary MR. So what we try to do, which was done in this particular case, not come out with one clip only. You want to bring it down that 4 plus MR to 1 plus. If possible. You will never make it 0, but 1 plus is allowed in this particular case. And so therefore, after the second clip became 1 plus.
More important, I think, when what you were discussing is that when you have primary pathology like this, and you have a, so-called Barlow's kind of a pathology, second clip is to stabilize the first clip, the decrease in mitral regurgitation was minimal.
Okay.
Yeah.
So you could see the V wave changes. Okay, we change by 10, 15 points and then another 10 points, so almost close to zero. But yes, if it is secondary MR, every clip decreases regurgitation by at least another 10 points each.
Okay, beautiful. So now, so we understood co-op trial, positive, severe MR. MitraFR was negative trial, but then the field still continues to propel. Why? Because the co-op was so positive. Both were decrease in mortality and decrease in heart failure, and both combined. Now we have the data up to 5 years. So now, what if we go to lower, moderate to severe MR? And now, in this day and age, you cannot prevent from having a clip in those cases. So what if you incorporate in the control group, then let's have a clip. If you are refractory to medical therapy, despite GDMT, compared to get a clip right from the beginning in moderate to severe MR. And this was the Reshape Heart Failure 2, which is the publication in NEJM and JACC simultaneously. After careful analysis, of course, those patients who are moderate to severe MR have a heart failure admission and then had high BNP. So every aspect of what could be the trouble, and more importantly, they had the primary endpoint of repeat hospitalization, first hospitalization, and KCCQ score. So this was the basically you see the 250 in the control group. 38 means about 15% require clip, which was done because of the symptoms and so with this I presented briefly earlier. Overall, it showed that the hospitalization for heart failure and hospitalization plus mortality combined favored even in moderate to severe. Although there are some severe in this case, about 30% was severe and moderate to severe was 70%, but there also clip showed and KCCQ score was superior device. Anything towards 100 is the number, higher the number, better it is. So the difference was much higher in the clip group. So basically showing that even in the moderate to severe is better. Now, what about the individual endpoint, particularly mortality? You can see overall mortality trended towards in favor of the clip, but in the cardiovascular cause was not different, but key is it still remain that overall it was a very safe device. And the question comes that how many patients require mitral valve repair, unplanned, which I should have about 10% shown there. So these are basically the individual endpoints and shown higher residual mitral regurgitation and so on and so forth. Now, another important point, that what is the predictors of hospitalization in the trial? One, use a device. Secondly, your baseline KCCQ score. And the third one was, if you are admitted beforehand, these were the three important predictor of repeat hospitalization in the Reshape Heart Failure 2 trial. So this basically the conclusion was that even for the moderate to severe, and there was guideline directed medical therapy, not too strong, but not like what was done in the co-op, not as little as was done in the MitraFR, but in between was done in this. So now you go for next. What about, we got to the severe, we got to moderate to severe. Now what about the moderate secondary mitral regurg or FMR? So there is the registry of the expanded from both USA and Europe, mitral TEER in management of moderate to, as I said, moderate mitral regurgitation and follow up this patient, and showing basically whether you are 2+ MR or you are 3+ MR, benefit is identical in every aspect: reduction, end diastolic volume, decreasing ventricular cavity, lower mortality, and also clear. Heart failure hospitalization is identical whether you're 2+ or 3+. And therefore, and then of course you can see here, repeat hospitalization, significantly improvement. So what does it mean? It basically means, put it nicely in this picture, the central, that even severe, moderate to severe or moderate, same thing like we are going to the aortic tower. So we're going to the, initially we were all various risk group, but also severe aortic stenosis, now with the moderate aortic stenosis, asymptomatic, all showing that this transcatheter options are going to win on a long run. We may have little trouble in some devices, but we are going to perfect it so that clearly a wide number of patients can be taken care. So I want to ask my colleagues here, they want to comment on this spectrum, that how CLIP has been superior or has done very well for moderate to severe and severe mitral regurg.
So
Gilbert?
I'll start. I think I said I was a co-author in this paper. So I think it means that certain patients, subgroup patient moderate and mild, might be even disproportionate in terms of the heart failure symptoms. So if they're already on guideline-directed medical therapy and they are moderate and mild and they're symptomatic, this shows that treatment, number one, is safe. Right, you don't want to harm the patient, and number two is efficacious. So my understanding is that there will be co-op 2 coming. In terms of moderate MR, symptomatic moderate MR. So we shall see. There will be a true randomized trial against now the contemporary GDMT, right? Because now you can have you have SGLT2 inhibitors, you have other options now that COAPT did not have. So we'll see whether the TEER or reducing the MR will win.
One point I will make here is that we have to understand disproportionality of MR, right? So you could have moderate MR, you could have severe MR, but has to be disproportionate. All these studies consistently tell us that it's not really one single. Remember, it's a dynamic valve. It's hemodynamics are very dynamic in terms of the mitral valve. So as long as it's disproportionate, you will help the patient. So that's the important thing. You can have proportionate MR and could be severe, but doesn't make much sense.
But I would say the other point also, and we have never seen that publication, that patients, remember we have for everything, PCI, bypass surgery, patient on optimal medical therapy versus not optimal medical therapy, outcomes are different. But has anybody analyzed, let's say in the co-op trial, so some patients were on the optimal guideline directed medical therapy, all 4 of them, but some of them could get only 2. And was there a difference in outcome? And if there's no difference in outcome, then why are we pressing so much on the GDMT? Why not just truncate for 4 to 6 weeks? If patient doesn't respond and knowing that the moderate MR will be beneficial, just go for it because there is no negative anywhere.
Right. So it'll be interesting to see what the protocol in the trial will look like.
Yeah. So co-op 2. So let's see on that one. So clearly we do moderate. Now then the question is what is happening with the overall mortality of the TEER? It seems to be overall numbers are going down. It still happens, but a small number, and in last 10 years and so on and so forth. So now these and the causes of death usually mitral regurg, tissue damage, and so usual causes which give rise, or the device issue, which is the incomplete cooptation or detached clip, which which is one of the common reason for the death in this case. Now, then question came: you are a big mitral TEER center, you are a big tower center. Does it mean that you are good for both? And this actually, from the TVT registry, this data comes from that is there a variation in the hospital M-TEER, very complex graph, but I just want to take it to this. If we can understand it, the TEER versus M-tower, a 30-day outcome, overall basically the conclusion was that there is a lot of variability in the M-TEER outcome, while less variability in the tower outcomes, and those both do not correlate. So why that should be? Just because of the technical issues?
Yeah, I mean,
M-TEER, like we showed here, is technique dependent. Very important. I think in tower is it's a selection of the valve. And I think there was other paper also. I think if you consider about technique, self-expanding is a little bit more technique dependent. And there was that paper showing if centers who are better with self-expanding do very well with the balloon expandable, not vice versa. So that is why TEER means somebody who is good at TEER means it's very technically dependent procedure and decision making exactly where to place.
And also it's more imaging dependent, right? That's why we have work with our imager as a co-pilot model. TAVR is mostly fluoroscopically driven. TEER, you have to be echo and thorough. So I think that's also important. Stan, you want to comment?
Is there a paper comparing a high PCI volume center and a tower center?
Not yet.
Not yet.
Maybe we do it.
Yeah.
Yeah, there's more standardization, right? You do 100,000 TAVIs in a year.
It's more imaging dependent, both fluoro and echo, and also is the anatomy. The anatomy, aortic valve is circular or oval, but this thing here is mitral valve is very more complex. So that's why I think you need more technical abilities on the interventional person and on the imaging. So it's that's the problem, I think.
Yeah, so same thing as Sahil just said, 100,000 tower, overall like 1.5 million towers have been done compared to the M-TEER or the TEER basically is about 18,000 per year, and overall only 160,000 TEER have been done worldwide. So big difference. So their conclusion was there is a modest correlation between the hospital level volume for TAVR and M-TEER, but low inter-procedural correlation of outcome. For similar patient site level variability for mortality and morbidity following M-TEER was high. Factor influencing outcome and center of excellence as a whole may differ for TAVR and M-TEER. So clearly you cannot say I am this center is for the expert in transcatheter valve intervention. It has to be the TAVR or TEER. Two separate, and you know that we actually part of this has been shown on various aspects. There is a accreditation and centers. Mount Sinai has been for the TAVR. There is no separate accreditation, and what basically paper trying to say is you may have a separate accreditation or making a center of excellence for aortic versus mitral. So that I think makes sense because there's a lot of variability for the mitral. So just to quickly go through this, I presented last month also about Matterhorn in surgical patiently functional MR, mitral repair versus the surgery overall. And these are the patients, activities are good. So just wanted to show at the background point of view, overall, no difference. And of course, advanced event safety point of view, the TEER is safe, but the problem is that 5% require mitral valve reintervention. So overall, and of course, there's no stroke. And so using the small study about 1 year. So idea there was functional mitral regurg, surgeries, people say this is a wrong trial because surgery is never part of equation, doing a functional mitral regurg. So this is but just to say what is in the literature, everything else from KCCQ, functional class, 6-minute walk distance, both were identical, but more important was the TEER required 8.9% has a severe MR compared to surgery very little. So clearly, overall you can say was no clear benefit, or identical, that in selected cases you could do it, and this is a nice central figure. Now, we go to next one. Next one is, what are the data of doing now the TEER against surgery in patients who are high risk or older patients. So this is a study in the older patient, basically the TEER versus the mitral valve repair in primary MR, degenerative mitral regurgitation, and overall answer is no good, NG. So TEER had, whether you have the residual less than 2+ mitral regurg or more than 2+, was inferior. In these patients, the high risk elderly patient, TEER was not good compared to surgical mitral repair. Comment?
I mean, like you just said earlier, it depends on who the TEER operators are and imagers are. So, I mean, if you can have strong surgeons and not so strong TEER operators and vice versa. So I think, there's some implicit bias. And also, in terms of the cohort, the comorbidities, we have to see if they're truly matched, right? This is not a randomized trial.
Right. So. But just, so this basically puts it together, that what happened is that 1 year mortality was 19.5% in the TEER group, and it was 3.9% in the surgical valve replacement with 0 hospitalization, and on TEER side, 10% hospitalization.
Yeah, but if you look at the age difference, it's 10 years older in the TEER group, so we expect the older you are, the shorter life expectancy, right? So
and more comorbid conditions.
Exactly.
There's no question there.
So that by itself self-selects them out for survival benefits. There's huge selection bias. Yeah.
So one thing for sure, if you want to compare yourself against surgery, make sure your MR is less than 2.
One or less. One or less.
One or less. As you can see, there's big difference. Yeah. There's otherwise big difference. You lost the game.
Yes.
So have you lost the game? Well, we don't know, because there are 3 trials at present. One is for the high risk patient with a short-term outcome of 1 year of non-inferiority, patient with STS predicted risk of more than 6%. There's all the trials of degenerative MR, primary MR. Second is the primary trial, basically patients in those who have up to 3 to 6 year follow-up, 65 and above, and patients various surgical risk, low risk, intermediate or high, age more than 65. Then the repair MR is designed to evaluate short-term non-inferiority across a moderate surgical risk patient, age more than 75 or STS more than 2, and comorbidity at 2 years. So these are the 3 trials are ongoing. Gilbert, you know any term in terms of how much have been randomization
So
so
repair
far?
MR is almost done this year. Primary is still a long way to go because and the other number one, the MitraClip just started. So yeah.
Yep. So just to say, the key is that the field has not gone. It is evolving, and we'll know over the years. So just to want to give you update in the mitral valve space, which we are part of, is the Intrepid, which is the early feasibly study. Very nice. Lot of changes are happening with the device. There's a primary cohort and versus MAC cohort, and of course. Based on the various experience, their inclusion exclusion criteria, and so far they have published the data of the 33 patients, which came out, and you can see here early and late clinical outcomes are excellent. Your regurgitation is gone, NYHA classification very good, and more importantly, look at the complication. Reoperation or intervention in 3%, but no all-cause mortality, no stroke, and of course the device thrombosis occurred in about 3.4% of cases 1 year. Of these, one case happened, so became 3.4%. How are we at present with this device?
So we are anticoagulating them for 3 months, but most of them are on some form of anticoagulation anyway because they're on Afib. After that, so we're actively enrolling and screening these patients, especially for secondary MR with reduced ejection fraction. I think those are patients that will benefit the most because we've seen that even with TEER, they come back with recurrent MR because of the progressive dilatation of the anatomy. But whereas if you replace the valve, there's no MR to worry about. What we need to follow up is basically how they do in terms of the remodeling and the KCCQ, and of course the the thrombosis that you mentioned.
Now, when you fail the tricuspid clip, you can do evoke.
Yes.
But if you fail the mitral clip, can you do Intrepid?
So right now, it's hard because you have to make the double orifice back in the single orifice, and people have done it with Tendyne because it's transapical. So people have done some, experimental where they remove the clip or they lacerate the leaflet to put a valve in, but there's a very, very early stage.
Okay. All right. So basically, just to say, overall, the device is good, and this field is ongoing, particularly from the Transseptal. The Medtronic with the Intrepid is ahead of any other valve for the Transseptal purpose of and Apollo EU are going on, and of course we'll hear more and more. So then few other things. There is the latest one about the Sesame, that is the myocardial bulge of the HOCM, particularly decreasing the obstruction, and this is a whole technique with Greenbaum, and so they are mastered in this electrocautery procedures, and nice data they have shown, particularly of making your device feasible, particularly in some patients with the tower as well as in the TMVR space. So we have not done ourselves at Sinai, but this is something very good. We actually do alcohol septal ablation. Gilbert, anything where we will be doing this?
I think it's complex in the sense that your first traversal has to be perfect. Otherwise, you have to go and create VSD, create other problems. So I think that's probably and then they have a very meticulous way to screen the septal angle, septal length. I think it's teachable, it's learnable, but the question is, you can see the procedure time is quite long, right? And what has been shown is that this is very effective for HOCM. Yeah. Whether it's effective for TMVR, for LVOTR, some we still don't know, but HOCM has been shown to be very effective. It's myotomy, not myectomy, right? In surgery, we take the muscle out. This is to open up the muscle, to fillet it open, to improve the outflow tract.
Beautiful. All right, Sahil, watch TEER. We are not doing enough watchmen. Why can't we do some cases combined?
Right. So, a couple of issues with this trial. As you remember, it took a long time to enroll these patients. And the biggest issue is obviously reimbursement. You're doing 2 procedures at the same time, adds to procedural duration. So we can do it. We've done it in patients if, they're out of state or they really request to be done on the same day. But definitely adds to procedure time. And the benefits are the patients can be taken off anticoagulation very quickly. definitely avoids doing a second procedure. So patient comfort is definitely there, but adds to your procedure time and loss in reimbursement.
Very good. Okay. So then there are a lot of data that if once a patient come back after the M-TEER with a severe MR, use any of those, I would call them funny devices. Have you done any of those cases?
No, we have not. There's the concern with the occluder is that you can cause hemolysis, actually. That usually happens because of residual leak between the two devices or in the commissural position. So I think that was not ideal. I mean, Cardioband is only available in Europe. I think that's actually been stopped. Carolon is only in trials. And then obviously, like you mentioned before, you can try to make the leaflet become one orifice again and put in a TMVR like you see here. But again, these are all in trials. There's nothing that's approved. So these are all performed with compassionate use.
All right, good. Let's complete it. So therefore, the MitraClip, even moderate to severe, do very good. So MitraClip should be considered early in the management of heart failure patients with prior hospitalization who remain symptomatic despite aggressive, which I put aggressive in the parenthesis, despite guideline-directed medical therapy. Then his randomized trial is small, showed that in the functional MR, we did good. TEER against surgical mitral repair, but if you do a primary MR comparison, M-TEER was not good, but 3 randomized trial will answer it. Then variability in the morbidity and mortality of the M-TEER, and the lastly, trials of dedicated TMVR devices are still ongoing, particularly Apollo had Intrepid has a good future. Now, 3 questions. Reshape heart failure 2 is not true. 1, about 15% patients in the control group receive bailout mitral clip. Mortality was significantly lower in the mitral clip group versus control group. Readmission for heart failure versus cardiovascular mortality was significantly lower in the mitral group, and higher number of patients remained in NYHA class in the mitral clip versus control group. And wrong is B. Mortality was significantly no. It was 0.09 for all mortality. Cardiovascular mortality was no difference basically with the clip. Second, true finding of the M-TEER versus surgical mitral repair for DMR in older patient. All-cause mortality at 1 year similar between 2 groups. Heart failure rehospitalization tend to be lower in M-TEER versus surgical mitral group. Higher in hospital mortality in surgical mitral versus M-TEER group, and similar major bleeding between 2 groups. So answer there is C. Higher in hospital mortality no, but identical in 2 groups in this trial. Then finding of the Intrepid early feasibility study, transcatheter mitral valve repair, almost no residual MR. They're saying what are the true finding, which is wrong basically. Almost no residual MR, no 30-day or 1 year device thrombosis, very high ASD closure, no hospital mortality and low 1 year mortality. And answer is device thrombosis does occur in about 4% of cases, but that hopefully will be mitigated by giving more anticoagulation therapy. With that note, I complete our presentation for today.
Okay, well, thank you so much for the heart team members of the Cath Lab, and thank you for participating in this exciting case today that will be available this afternoon for your review at ccclivecases.org. Remember, our structural heart life cases are every month on the second Tuesday at 9 a.m. The next one will be April the 8th. Thank you so much.